Good morning, good afternoon, and welcome to our webinar. My name is Amy Cross, and it's a pleasure to welcome you to Moleculera's webinar on utilizing the Cunningham Panel in clinical practice. If at any time you have questions, please use the chat or Q&A function, and we'll answer your questions either on the spot or during the Q&A portion at the end of the presentation. We will also send you a recording of this webinar within the next 2 or 3 days. Leading today's discussion is Dr. Craig Shimasaki. As a brief bio, Dr. Shimasaki is a scientist and inventor with a passion to translate scientific and medical discoveries into acutely needed products so that patients can live longer, healthier lives. He is the co-founder with Dr. Madeline Cunningham and is the CEO of Moleculera Labs, a neuroimmunology precision medicine company focused on identifying the underlying roots of neurologic, psychiatric, and behavioral disorders triggered by an autoimmune response. He has spent over 35 years working in the fields of molecular biology, viral pathogenesis, and infection-triggered neuropsychiatric disorders. Dr. Shimasaki started his career at Genentech and continued to work across all stages of research, development, clinical trials, and regulatory approval of technology from bench to bedside. His research work includes epitope mapping of HIV proteins, genetic-based predictors of breast cancer risk, influenza and RSV diagnostics and therapeutics, and for the past 10 years, the pathogenesis of infection-triggered neuropsychiatric disorders. He has co-founded multiple companies and led multiple products through the FDA approval process and is the co-inventor on multiple patents. Dr. Shimasaki received his BS in biochemistry from the University of California at Davis, his PhD in molecular biology from the University of Tulsa, and his MBA from Northwestern University, Kellogg School of Business. He is an adjunct professor at the University of Oklahoma. Internationally, he teaches and mentors scientists, physicians, and biotech leaders in how to translate their discoveries into acutely needed medical interventions. So, without further delay, Dr. Shimasaki, the floor is yours.
Good morning, wherever you're located, and it's a pleasure to be able to speak to you about something that is really near and dear to our hearts, and that is infection-triggered autoimmune neuropsychiatric conditions. And what I'd like to share with you is a brief overview of some of the biology that goes on behind this, and then how prevalent it actually really is, and potentially one of the keys to helping identify, diagnose, and even treat successfully patients who are struggling with many chronic neuropsychiatric and behavioral disorders. My name is Craig Shimasaki. I'm the co-founder and CEO of Moleculera Labs. And I'm pleased to share with you today a little bit about how the product or the tests that we perform in our CLIA laboratory can help you with identifying patients and helping to guide treatment for those that have these chronic conditions. So there are about 4 topics I want to cover today. The first one is the biological basis of how these infections can actually trigger autoimmune dysfunction, and how that ends up resulting in various neurologic, psychiatric, and behavioral disorders. Then why certain infections tend to be present in patients that have these autoimmune neuropsychiatric disorders. Some of these conditions can include PANDAS or PANS, another condition called Neurologic or post-treatment Lyme syndrome. Even now, more recently, what we call long COVID, or post-acute COVID, SARS-CoV-2 sequelae, but even things that might be diagnosed, such as even ADD, ADHD, autism, chronic depression, and other types of disorders. We'll talk a little bit about why portions of those might be actually infection-triggered autoimmune. And then we'll share a bit about how the Cunningham Panel can help diagnose and direct the therapy to the underlying etiology of these patients that have immune-mediated neuropsychiatric disorders. And then we'll talk a little bit about what are the common symptoms that generally are recognizable in these patients, and then some of the general therapeutic categories that have shown clinical effectiveness in treating these patients, because we have some really amazing testimonies of patients who have been chronically ill for multiple decades who no longer are on medications but are all doing very well. So with that, let me share you a little bit of background. The neurologic, psychiatric, and behavioral disorders are diagnosed today based on symptoms. And so I have a handful of symptoms up here that you can see, and then a handful of diagnostic categories that are related to this. So, for instance, if an individual presents with motor or vocal tics for more than 12 months, that is the working definition of Tourette's syndrome. Patients that might have repetitive behavior, hyperactivity, difficulty in school, separation anxiety, irritability. There's potential that they could be diagnosed with other disorders such as ADHD. In some cases, other disorders or other symptoms might lead to an autism spectrum disorder diagnosis. And what you can see, the point being is these are not biological at components or even testing. They're based on symptoms. And so they're looking at, and today in the medical system, is classification by symptoms. And the challenge is that psychiatric disorders, which are diagnosed by clinical presentation, they don't have really anything to do with the underlying biology. And the other issue is that these disorders have a wide range of symptoms and causes, or why we call them spectral disorders. And then that also means that they're going to have varying responses to treatment because you may not be particularly talking about the same underlying root cause. Well, the standard of care in medical care for neuropsychiatric disorders is, of course, focusing on the on the symptoms, and the treatments are directed towards treating symptoms and often coping. These include a whole host of psychotropic drugs and then psychotherapy and institutionalization if patients don't respond appropriately. The counteracting side effect of the use of many psychotropic drugs have black box warnings where the FDA does identify the potential for things such as suicide and other types of different symptoms. Now, it doesn't mean that these don't work effectively. In fact, they do in patients who are responsive to these and their underlying etiology has to do with these particular different etiological causes. So what we want to move to talking about is these brain-reactive autoantibodies. And they've been known in medicine for a long time. What you can see here is that there is a very long list of many different targets that have to do with targets in the brain, the central nervous system, other areas of the body that do trigger and result in various types of neurologic, psychiatric, and behavioral disorders. So this phenomenon is not new. It's actually something that is seen, and many of them are also either associated with paraneoplastic syndromes or potentially sometimes in the case of maybe cancer. What you can see here is a graphical illustration of some of the mechanisms. This one is an NMDR receptor encephalitis in which these antibodies will bind to various receptors in the brain or in the neurons. Very similar components here in different types of these neurologic and psychiatric conditions in which the immune system is interfering with normal function. So that brings us to another portion of this, the blood-brain barrier. What we measure and what we're going to talk about later is the ability to identify whether or not these antibodies are present in the serum of patients, and then their ability to cross the blood-brain barrier and then interfere with the normal neurologic function of the brain or other central nervous system parts in a patient. Now, you kind of wonder about medical research and literature. The term autoimmune encephalopathy, which is one of the terms I've looked up here, between 1946 and 2021, you see this exponential increase in peer-reviewed published medical and research articles describing and identifying this autoimmune encephalopathy. We'll talk a little bit more about what that means but the very similar type of explosion in the recognition of these in called autoimmune neurology, neuroimmunology, neuroinflammatory disorders, and even autoimmune encephalitis. Some of you may have seen the book or the motion picture called Brain on Fire. Brain on Fire is the story of Susanna Callahan, who is or was a New York Post journalist. As an adult, she suddenly developed this psychosis, this violence, this instability that required her to be in the hospital, and which was very puzzling to the doctors. It was identified that she had an NMDR encephalitis, which was autoantibodies that were attacking the brain and triggered by an infection. So there's a book that she published called Her Month of Madness. And then Hollywood's pretty good at taking something that may be popular and putting it into a motion picture. But it is a good view of one of the more severe episodes in which you see where these autoantibodies began to interfere with the brain. There's also other studies that have been published on the association with streptococcal infection and brain inflammation, particularly in an area called the basal ganglia. So this is a study that shows that the inflammation in children with OCD and tics associated with strep infection have an increased volume in the caudate, the putamen, the globus pallidus, but not the thalamus, which is not part of the basal ganglia. Well, the basal ganglia is responsible for motor movement, procedural learning, and cognitive functions in the brain, as well as emotional functions and even eye movement. So what you can see that is if antibody interferes with the normal function of the basal ganglia, potentially you could see symptoms related to motor movement, learning, cognitive functions, and emotional functions, etc., which we'll talk more about in just a second here. Again, medical literature such as JAMA Psychiatry in 2019 has published a study of over 1 million individuals in Denmark where they were able to follow individuals from birth to age 18. And what they found was that if someone was hospitalized for a severe infection, that the risk of developing mental disorders increased by more than 80% for a diagnosis of schizophrenia, autism, OCD, ADD, ADHD, ODD, and tic disorders, and many others. And the question they posed in an accompanying editorial was, how could exposure to infections affect the brain mechanistically to give rise to mental disorders? Well, they said circulating autoantibodies that enter the brain via a compromised blood-brain barrier bind to neurotransmitters is a potential explanation, and this mechanism has been proposed in PANDAS and other mental disorders. For those that aren't familiar with PANDAS, which is an acronym that has been more recently described in the last couple decades, a pediatric autoimmune neuropsychiatric disorder associated with a strep infection. So how does this really occur biologically and mechanistically? Well, we all know that we all get some type of an infection, whether it's bacterial, viral, fungal, etc. It's something that we all get and we all have contact and get in contact with. Our body produces antibodies, which is a normal function of our biological system. And we're very familiar with that because vaccination is intended to develop antibodies that will neutralize, in the most recent case, SARS-CoV-2. And then we also know that in the cases of these patients that actually have antibodies that cross-react with neurologic receptors, we call this process molecular mimicry, in which a part of the organism has an identical part that is very similar to or identical to a part of the body. In this case, it's the neurologic receptors. So once these antibodies are produced, they will cross-react with, in this case, neurologic receptors, crossing the blood-brain barrier, and then in these cases interrupt normal brain function, particularly what we're talking about here is the basal ganglia, through what we might think of as friendly fire during the wartime. And that results in these various neuropsychiatric symptoms associated in this case with the function of basal ganglia. Again, anxiety, aggression, rage, OCD, tics, depression, hyperactivity, insomnia, phobias, and the list goes on. And again, because the current standard of practice for medicine is that patients will routinely be treated symptomatically. And in many cases, and often the case when these are infection-triggered autoimmune, patients do not respond. In fact, often what we see is they actually may even worsen. And an interesting observation is that SARS-CoV-2, which now has triggered a very large percentage of patients with long-term, what's called long COVID, which does include neuropsychiatric symptoms, but also cardiovascular symptoms and fatigue and other things that are associated with interference with the brain and interference with the cardiovascular system. Again, the belief and what is understood currently is that there is a triggering of the immune system, and that immune system begins to be directed towards a portion of the virus that is common to a portion of our body, hence the brain or hence the cardiovascular system, cross-react and interfere with that. So just to cover a little bit about the nomenclature and why some of this can be confusing, but they did mention PANDAS, and some of you may have PANDAS patients who are familiar with the symptoms. PANDAS, again, stands for Pediatric Autoimmune Neuropsychiatric Disorder associated with a strep infection. It's also been identified and determined that there are other microbes that trigger this other than strep. And there's also been postulated that there are also environmental and other biological factors. So there's two different avenues in which it's believed to trigger these, and that is infectious agents and non-infectious agents. So in 2015, a group of clinicians and researchers convened at Stanford and proposed a term called PANS, which is Pediatric Acute Onset Neuropsychiatric Syndromes, which excludes the particular reliance on streptococcal infection because other infections can also stimulate this. And then also, it's also known, and this is another proposed term called ANDL, which is autoimmune neuropsychiatric disorder associated with Lyme in adults, because technically, if you're an adult and you end up with this mechanism or this syndrome, you can't have PANDAS and you can't have PANS because you're not pediatric. So there is another term here that's been coined called ANDL, and there seems to be other terms that are trying to encompass all of these. One of them is basal ganglia encephalitis, and the other is the term I mentioned, autoimmune encephalopathy secondary to infection. Now, whatever you call it, what we're talking about is an infection-triggered autoimmune neuropsychiatric syndrome. And basically, the term encephalitis refers to just an inflammation of the brain. And as you recall in one of those slides, you could see that the immune system was triggering inflammation, in particular in these patients with post-streptococcal infections in the basal ganglia. The other term is encephalopathy, which is basically just a term used to describe a disorder or disease of the brain. There's also some nomenclature, or I should say some convention, that sort of identifies these terms in a way that tend to be thought of as direct viral infection or certain types of limitations. But in the usages of these terms, we're referring to an autoimmune triggered attack on the brain or the central nervous system that's mediated by an infection. Well, lo and behold, infection-triggered autoimmune neuropsychiatric disorders are not new. So rheumatic fever, which we don't see that in many of the developed countries anymore, but it is still around. And this is a post-streptococcal infection in which the antibodies began attacking the heart or the heart valve. But one of the effects, or I guess the syndromes that also was associated with it, was these bizarre and precipitative behaviors. They called it chorea minor. And also it was then known as Sydenham's chorea, previously known as St. Vitus's dance. You would see abnormal movements, loss of motor control, loss of emotional control. And the biological understanding of it is that a strep infection would trigger antibodies, but the antibodies made within these individuals were also directed against a part that was very similar to the heart, and then also very similar to the brain, in this case, the basal ganglia, which again results in what's known as Sydenham chorea. The treatment in these cases have been, as is well known and understood, to be a penicillin or an antibiotic, which then removes the strep infection and then also over time reduces the immune response. So the term we use is called molecular mimicry. And molecular mimicry, you're going to find, is also something that is proposed in what we're seeing with long COVID, but also other types of disorders that include various other types of chronic disorders are seeing an infection trigger association. Well, certain parts, as I mentioned, of an organism, in this case, the group A carbohydrate and the M protein on the streptococcal bacteria, has similar sequences to parts of the body. Normally, our body will say don't make antibodies against these because there's a self-non-self dysregulation as to what's us and what's not us. Well, in rheumatic fever, in those patients that have this autoantibodies directed against the heart valve, they will also see that these antibodies are directed against certain parts of this particular organism. We mentioned Sydenham chorea, where patients will have antibodies directed against the basal ganglia, but we also see patients that have arthralgia, where these antibodies then are directed against the joints. They can be directed against the kidney and others, and therefore you can see that this chronic debilitating condition resulting from a streptococcal infection or another infection that ends up with a very large number of different heterogeneous symptoms that make it very difficult for diagnosis. So one of the things that we do see in many of these patients is that there are certain infections that tend to be more frequently associated with these infection-triggered autoimmune encephalopathies. These include strep, obviously, which is where PANDAS got its name, but also influenza A, and varicella, mycoplasma, of course, Lyme disease, Babesia, Bartonella, Coxsackie virus, and others, including now SARS-CoV-2. So again, the reason being, which we won't have time to go into today, is that a part of these organisms use a specific letter or combination of letters in the protein alphabet that are identical or very similar to the same sequence of letters in the protein alphabet in either our parts of our brain, target receptors in the nervous system, and other areas of the body. One of the things that we have found, which is really what is the reason that we exist, is that we see some really amazing patient recoveries when patients are properly diagnosed and treated. This is a snapshot of a video Grace's mom sent to us. And actually, you can see the video on our website called Grace's Story. She was diagnosed with ADD, ADHD, and OCD, and other mental disorders at 8 years old. In fact, this was a picture of her wanting to try to kill herself. And the parents emptied their 401k twice and no answers. They found out that we had and do these testing, and her treatment was changed. And so just recently, her mother sent us this picture of her. She's on the cheer team, back to normal life, grown up, and doing well and off all medications. And we have hundreds of stories such as this. One of the things we are doing also is to try to define the financial impact on the parents and patients with these autoimmune neuropsychiatric disorders. These are a handful of comments from over 1,000 parents who this survey was sent out to answer certain questions. And as you can see, the burden of really the financial burden not to mention the social, the psychological, the impact on families is great. And so that summary of this is something we're working on a manuscript. And because we now have tested over 13,000 patients for these autoimmune neuropsychiatric disorders, we found that patients from this study have visited between 5 to 15 doctors before they receive a proper diagnosis. And the length of time from their symptom onset to diagnosis is sometime between 3 to 5 years. And then another 3 to 18 additional months before they get effective treatment. Our goal is to diagnose and identify these patients very early and then be able to direct them towards physicians who understand, such as yourselves, this clinical disorder or this syndrome, to be able to effectively treat these. So what are the commonalities in these patients, excuse me, that present with these positive anti-neuronal antibody tests we use in the Cunningham panel? Well, some of the things that we see are that many of these patients have a sudden or rapid onset of neuropsychiatric symptoms. It could be very early on in life or at early age, or even later we see that there's adult onset. So they have these onset of neuropsychiatric symptoms that didn't exist before, rapid or sudden onset of obsessive compulsive disorders. Sometimes there's a restrictive eating disorder, and this is more of an OCD that's a fear of food contamination or other problems such as fear of choking. Patients may have motor or vocal tics or what's called choreiform movements, these little piano playing type of movements. Anxiety is one of them. Rage, hyperactivity, separation anxiety, emotional ability, depression, developmental or behavioral aggression. And because of part of what we'll talk about at the end, how these targets are tied in with different parts of the nervous system, there can be dilated pupils, mydriasis, urinary frequency, and bedwetting in older children, relapsing, remitting, and this dramatic abrupt exacerbations. Sometimes, and more often than really we would care to think about, is that suicidal ideation accompanies this. And one of our physicians that works with us quite frequently have indicated that every one of her patients have admitted to suicidal ideation when asked. And some of the people and the parents and then even other clinicians we work with unfortunately have lost patients to this situation because it was prior to their ability to get treatment and sometimes inability to get properly diagnosed. We also see treatment resistant to standard neuropsychiatric drugs. Patients may be diagnosed with PANDAS or PANS. Family history of autoimmune disorders. Again, this is a hallmark in that we're looking at a self, non-self dysregulation when an antibody is made based upon an infection. Then the frequency of infections, often there are multiple infections, and we'll talk about this a little bit more in a bit, because many of these infections can be subclinical, meaning that there won't be symptoms that would be outwardly noticeable. Other diagnoses can be neurologic Lyme or post-treatment Lyme disease, in which Lyme is also another causative agent. So let's shift our attention to, okay, now we understand the little bit of how the biology occurs, what the disorders are, what are some of the symptoms. Now let's look at what are the biological targets that actually we have seen and have identified that occur in these patients and identified in what we call the Cunningham Panel. So this is actually the result of targets that have been worked on for over 20 years of research in the lab of my co-founder, Dr. Cunningham. And they've identified that there are 4 biological targets in a cell stimulatory assay in which these patients have antibodies directed against. They include the dopamine 1 and 2 receptors. There are 5 receptors in the brain that actually help conduct the nerve transmission between pre and postsynaptic neurons in the brain. And then the myelin sheath, or the lysoganglia side, which is makes up the myelin sheath around the nerves. tubulin, which is heavily concentrated within the brain, and then what we call this CAM kinase activity, which I'll briefly talk about in a minute, which is an enzyme in the brain that actually synthesizes and is a part of production for these neurotransmitters in the brain. So if you look at this graphically, antibodies that interfere or bind to lysoganglioside D1, D2, or activate CAM kinase interfere with the fidelity of the neurologic transmission and the interference between normal brain function within the basal ganglia. And so that's an important component that's vital to understand, is that if there's an etiologic root that has to do with an infection-triggered autoimmune condition, that you want to treat the root rather than the symptoms. So we've conducted studies with many of these patients. Again, remembering we've tested now over 13,000, almost 14,000 patients. And what we find is there's some symptom association with patients who have autoantibodies against dopamine D1. They tend to have more of the psychiatric symptoms, mood instability, anxiety, irritability, aggression, and many more. When they're associated with D2, we find that they are associated with more movement symptoms, choreiform movements, and hyperactivity. Again, additional components are seen with them. When they're associated with antibodies against tubulin, what we find is that there is usually a presence of obsessive compulsive disorders and maybe some things that people will refer to as brain fog, that they have difficulty focusing, concentrating, remembering, things like that. And that's now also not uncommon in patients that talk about chronic fatigue syndrome. There are other types of symptoms associated with antitubulin that we see in many of our patients, and they're listed here. When there's antibodies directed against the lysoganglioside GM1, again, remembering it's the myelin sheath or its components of the myelin sheath that are around the nerve that help conduct the signal down the nerve axon. We see that these are associated with tics. They tend to correlate with complaints of joint connective tissue pain, and as you can see, sleep disturbances, sensory abnormalities, and other behavioral aggression. So this is what we call a CAM kinase 2. It's actually an enzyme, but we're actually doing research here to understand how an antibody can actually trigger this enzyme to be activated, because it's associated with fight or flight behavior, separation anxiety, urinary problems. And the other thing we find is that when this is elevated, that there is often an active infection or multiple infections within these patients. Again, we see that these symptoms can be associated with reactivation, earlier stage illness, but typically it's activating this fight or flight behavior. And so you see this anxiety, you see this insomnia, you see these other things that include anxiety. And these patients also tend to be more responsive to particular immunotherapy that we'll talk about in a moment. So calcium calmodulin kinase 2 is a long name for an enzyme that, as you can see, is involved in many of these other receptors, and there's interference and communication with them. We're in active stages of research to identify how these things are involved, and then how these antibodies that affect it actually can stimulate it, and how it's tied to disease, and how its treatment actually improves a patient's condition. So one of the things that you will get as a clinician when you order the Cunningham Panel will be this report. It's actually pretty long. The first page is simple. All 5 targets are listed here with their results above or below within normal range. The other thing that you'll see and you'll get is the symptoms, but also the sensitivity and specificity, which we'll go over in just a second for a study here, and the correlation that I mentioned with these different symptoms, as well as the accreditation for the lab and some background on the targets, and then literature references that if you're interested in learning or looking up more about these, or maybe hints on other types of treatment modalities, these are listed here, as well as a copy of the Journal of Neuroimmunology that we published 2 years ago, showing a clinical study retrospectively identifying about 58 patients before and after treatment, which I'm going to show to you right here. So this particular study, which is available online or on the report, is where we identified patients who had 2 or more panels run and looked at their treatment before and afterwards and found out whether they improved or didn't improve. And then we looked at whether or not the presence of those antibodies correlated with their symptoms and whether the treatment was effective. So within that study, what we found out was that all patients had multiple co-infections. These are just representatives of many of the infections that these patients had. And those that don't mean that they're all there. It just means that these patients had a very large representation of these different infections. Now, one of the things is remembering that strep was a trigger, Lyme was a trigger, many of these other Mycoplasma, Babesia, Coxsackie. But we find that patients' immune system can be compromised, and therefore other what we might call opportunistic infections are also found in these patients. We also identified that both in those that got well and then didn't get well, they all had very similar types of symptoms: decreased concentration, OCD, irritability, depression, anxieties, sleep disorders, etc. So in that group who improved and resolved after treatment, we looked at their panel results on all 5 tests, put them together in a heat map. And what you can see, all patients had 1 or more of these tests were positive. In this group who actually began to improve after treatment or completely resolved, we found that this was the post-treatment results. So many of the patients had all antibodies back to baseline. Many of them had multiple reduced symptoms as far as tests, and they were either improved or they were totally well. What we also determined from this is what's the accuracy of the test in identifying and correlating with symptoms with antibody presence or absence. The accuracy was 86%. We're also working on improvements with artificial intelligence and algorithms to weight these tests and to look at, we can actually increase this to 90% accuracy. So you'll find that in that journal, the publication, you can read more about that. In this case, what we will find, I'm going to silence this. A couple of case studies really quickly. Is this young man who was presented with OCD, tics, and a decreased appetite. Again, he lost 30 pounds, but this is not an anorexia, but really an inability, a food phobia in which they were either had a fear of contamination or fear of choking. You can see only one of the antibodies were present in this case, and this is why we run these, is because we don't know which ones will be positive. The patient was treated with intravenous immunoglobulin and resulted in all symptoms reduced, and patient was well. So both had both IVIG and plasmapheresis. In this case, for a young girl, she was 9 years old. She started out with verbal tics and stimming, which is an autism-like behavior, a whole host of abnormalities, urinary and sleep problems, dysgraphia, inability to draw. And she had 2 positives and 1 borderline. The good thing about this is we believe what we caught was at least a patient that had a subclinical infection. They tested, found she had a treatable infection. They treated her with azithromycin and all a rapid improvement of all of her symptoms. And you see these went back to baseline. We have hundreds of these case studies in which we're working on publications with, and we see a very similar overarching result. There are other published studies which you can look up, and we can be happy to share them with you in Lyme disease, in autism, in other conditions such as even schizophrenia diagnosis. But again, remembering these are also diagnoses that are made by symptoms, therefore it could be etiology that might have to do with autoimmune. So the goal of precision medicine is to identify and treat patients based on their underlying root cause. And that's really what we can do right now. So we can identify patients that are autoimmune etiology and those that are not. For those that you run and you test and they're positive in the Cunningham Panel, we are working on, with artificial intelligence, to be able to predict which treatment responsiveness would be even much better. Now, we do know patients will respond to these, but there is also the likelihood that some may respond better to certain ones. But when you treat the immune system and the infection in these patients and their inflammation, we see remarkable results. So very quickly, how do you order the test and the process? Many of you have placed orders already. It's determining whether or not that patient is a good candidate for that. The blood then comes to us. We have blood centers that we can direct people to, but we're also working right now with Quest to be able to allow them to go to the Quest location. The pricing is $9.95, and we require a $4.95 deposit, but we also bill insurance on behalf of the patient. FedEx brings it to us overnight. We run all of the 5 targets in the brain that I mentioned. Within 2 to 3 weeks, there'll be results available. We review them. They become available on the laboratory information management system. The report is uploaded and published. We also courtesy bill, as I mentioned, to the patient's medical insurance. You as a clinician will then be notified that it's available. And we also have the availability of a consultation and other types of support services. So what are very quickly some of the general therapeutic modalities that have shown effectiveness for these autoimmune conditions? Well, the good news is that we've seen very strong clinical effectiveness is demonstrated if there is a biological evidence of this autoimmune neuroinflammation. So our clinicians report to us these things that they find. So the first thing really is to identify and treat all the infections. Remembering these infections are triggering the immune system to produce antibodies. These infections can be viral, bacterial, fungal, etc. And we remember that patients have and tend to have multiple infections. So treating one infection and patient maybe having 2 or 3 infections may not completely eliminate the symptoms. And they also remembering they stimulate these antibodies. Many patients, there's a need to treat these symptoms because patients are suffering. And so I'll show you some guidance here that's been published about that. You also then treat the inflammation or the inflammatory pathway because the immune system is responsible for stimulating this inflammatory pathway, but also this inflammatory pathway is also contributing to these different types of responses. Then treating any remaining immune or dysregulatory or dysfunction in the immune system. And to summarize that, you would see something like this. They may be antimicrobials like antibiotics or anti-infectives or antifungals, things that treat the inflammation like steroids or NSAIDs. Plasmapheresis is another one that is for the immune modulation, intravenous immunoglobulin, and even in some cases, rituximab, which removes the B cells. Symptomatic treatment such as cognitive behavioral therapy and low-dose SSRIs. So they fall into anti-infectives, anti-inflammatories, immune modulators, and temporary symptomatic treatments. For those that you would like some references, the Journal of Child and Adolescent Psychopharmacology has published some guidelines for PANDAS and PANS. Remembering PANDAS and PANS is a model for many of these different disorders that we've described. And so there's treatment management guidelines there. And that's available at the PANDAS PPN, which is a PANDAS Physician Network, or on our website. So we believe that this is the tip of an iceberg, that there's many other disorders that are associated with this and a very similar mechanism of infection-triggered autoimmune. And the brain is the last frontier in medicine. And our goal is to help change and improve how medicine is practiced for those with these neurologic, psychiatric, and behavioral disorders. And not to forget that our lab provides free consultative services. So, provider, you can call our direct line or call Amy Cross, our nurse. All the questions can go to the office for logistical pieces. We have in-service education for the symptom association, the biological targets. You just have to request that. We also provide resources for you as a clinician or for your patients There are videos and publications on our website at molecularalabs.com. And then you can download or order educational brochures for your patients on our website. And we're all about education and helping to understand how these types of conditions can be identified, treated properly, and resolved. So I'm going to close with one of my favorite TAC laws here. It's by Dr. Sidney Baker, who is involved in the autism movement. And I've adapted this slightly. He has a TAC law that says if you're sitting on a TAC, the treatment is not to Advil every 3 to 4 hours. So the treatment for TAC sitting is TAC removal. And that really just means you need to search for the root and treat the cause rather than the symptoms. And then a corresponding TAC law is that if you're sitting on 2 TACs, removing 1 TAC doesn't eliminate half of the symptoms. So you really have to treat all of these different underlying conditions. And by simply treating one of the conditions does not mean that you're going to see a 50% improvement. So be effective, you have to address all the underlying issues, meaning infection, inflammation, and the immune system. And with that, we see some very, very remarkable results. And I'm going to close with that our mission is to bring hope and healing to those suffering from autoimmune neuropsychiatric disorders. When I started the company, it was really an outgrowth of patients who were calling for over a year and a half, who were not included in a study that was able to help identify the underlying root cause. And then patients were being treated and got well and told other parents. And what we find is that there's a desperate need for these different types of tests and treatments. And our goal is to help you. So you're the ones on the front line. We appreciate all that you're doing. And our goal is to continue to be able to add to what we're doing. Although the pricing in some cases people think might be expensive, it still doesn't cover our costs. And so I go out and I raise capital from many people who are supportive of what we're doing. In fact, many of the early parents whose kids or children got well have been part of our supporters. So we appreciate you, and I'm going to close with that if we have any time for questions. But thank you for being at the front line and taking care of the patients, and we're here to support you in doing that.
Thank you, Dr. Shimasaki. That was an excellent presentation, as usual. We are open for questions. If you would just put your question in the chat bar, I will relay it to Dr. Shimasaki, and we'll try to get some answers for you. Okay, first question. How do you know if a patient is appropriate for Cunningham Panel testing?
Yeah, that's the very important question because as we talked about, there's a lot involved in the testing and it's a lengthy process, is if you see those symptomatic components, really the sudden onset is usually a trigger. The second identification is that they are resistant to what you might think of as standard of care for treatment for these different conditions. And those two situations are pretty helpful in the hallmark. The other is you might find that there may be a family history of autoimmune dysfunction, and some of the dysfunction could be as simple as maybe asthma or maybe even things like psoriasis, but certainly lupus, MS, other things that indicate there might be a predisposition to an immune dysfunction. And then the other is patient's history. They describe something as being somewhat normal and then changed over time, or maybe infections that seem to be associated with, but again, these could be subclinical. So it is maybe about those 3 or 4 different components that begin to make you think this could be autoimmune and it's worth testing the patient.
Thank you. Our next question asks if the Cunningham Panel is useful for adults.
It actually is, and we started as a result of the children's study, and many of these children got well. But again, children not only do grow up and become adults, but we are seeing many adult onset. And this is something that we are looking to work on publications with. We have a number of clinicians who use it in their adult population. One caveat is that the normal ranges that we have used in this study in the beginning for validation were on a pediatric population. Now, the potential is that maybe they might be slightly different in adults, but clearly if elevated and greatly elevated, it is a good indicator. But we are in the process of also conducting some studies to determine what an adult normal range might be.
Dr. Brown is asking, I think, a very important question. They're all important, but this one particularly stands out. He's asking if we have educational materials to provide conventional medicine only physicians who need to be convinced that this condition exists.
That's a great question. We are working and do work on those. Some of what we're trying to do is through these educational webinars. I'm giving a couple of talks at other conferences and the publications. And so if you have patients and case studies you'd like to work with us, the methodology for acceptance in medicine is multiple peer-reviewed publications. And we and others are working on that. But as you well know, medicine adopts things very slowly at the expense of patients and their health. We look for working with open-minded clinicians such as yourself because it is through that unified voice, the plethora of data and information, the peer-reviewed publications and the patients getting well is what will overwhelmingly change this. The publications, a couple of them you see, were in very, very well-respected journals like JAMA Psychiatry. You're seeing other ones coming out. But again, we're looking for help to be able to do that, and there are many, many opportunities. But if you'd like to talk more, we'd love to be able to work with you on something that could be helpful.
Thank you. A couple practical questions have to do with whether or not antibiotics or psychotropic medications are likely to interfere with Cunningham Panel testing.
Yes. So those are also good questions. What we do see is that those medications that don't interfere with the immune system do not impact the results directly. Now, if an antibiotic removes the infection and the patient's antibodies go back down to normal or symptoms are gone, indirectly, yes, they'll have a better result. As long as the patient is symptomatic and they're not on the immune modulatory therapy. When I say immune modulatory, what I mean is, let's say prednisone or any steroids or IVIG that would be putting exogenous antibodies into the body and making then we're measuring exogenous antibodies. So outside of those, we don't see that antibiotics or any kind of psychotropic drugs impacting the results. Again, as long as the patient is symptomatic, because this is a metabolic test, as long as the patient is symptomatic and not on immunomodulatory therapy, so far we have not seen that impact on the results.
Thank you, Dr. Shimasaki. I don't see any other questions, so at this point, I would like to thank everyone for joining our webinar. As a reminder, you will be emailed a link to the recording. That should take us about 2 or 3 days. If you would like to speak with any member of our clinical team, please do so. Dr. Shimasaki put the numbers on one of his slides, so feel free to reach out. We will do our very best to help you. So again, thank you very much for joining us today, and hopefully we'll hear from you all in the future. Thank you so much. Thank you, Dr. Shimasaki.
Thank you, Amy.